to mention that this session will be recorded, so I hope that's fine with everyone. Now, welcome again, and my name is Gloria Wong from the Department of Social Work and Social Administration, the University of Hong Kong, and this is the last section of our TIPCAT research seminars. And tonight we have, so the previous two seminars, last Wednesday and yesterday, we have been focusing a lot on the situation of dementia in wider Chinese populations. And tonight we have a very exciting program lined up. So we have 3 presentations focusing mainly on Hong Kong situation. So I would like to, without further ado, because of the in the interest of time, I would like to introduce our first speaker. So tonight we'll talk about both care and cost in dementia in Hong Kong. And our first speaker, Dr. Jacky Choy, he is currently research assistant professor in our department. And Dr. Choy is an applied social scientist interested in promoting informal care provided by multiple family care members and also other types of informal carers, as well as improving the well-being of caregiving families as a holistic unit. And Dr. Choy has over 10 years of experience in local research in aging, and has a comprehensive understanding of the social care and healthcare system in Hong Kong, partly related to his work that he's going to share with us tonight. And Jacky was involved in mixed methods research in relation to the development of a few major aged care and support services in Hong Kong, including a major project that I was also involved in, the enhancement of the long-term care infrastructure and evaluation of the carer allowance schemes and evaluation of the dementia community support scheme in Hong Kong. And more recently in the project TIPCAT, he and his associates conducted an in-depth review on the dementia situation in Hong Kong that covered the dementia care systems, policy awareness, epidemiology, informal care, social protection, and research and innovations. So I think let me pass the time to Jacky, who's also our graduate, to talk about the dementia situation in Hong Kong, the key challenges and opportunities. Jacky, over to you.
Okay, thank you, Gloria. Thank you for a very detailed introduction as well. Okay, so let me share my screen first. Can you see my screen? Okay. Okay, welcome everyone. So this is Jacky Choy from the Department of Social Work and Social Administration in the University of Hong Kong. So in today's sections, the whole sections, like what Gloria shared, it will be about care and course in dementia in Hong Kong. And I will be presenting on the dementia situation in Hong Kong, about its key challenges and opportunities. Okay, so I just have to I say it very clearly, it's not my individual work, it's really a collaborative efforts for the whole TIPCAT project team. So you can see the names and affiliation here. Okay, so thanks my colleague very much, and today I'm presenting on their behalf. Okay, so at the very beginning, let me provide some background about the dementia situation in Hong Kong first. And this is also the background why we actually started the TIPCAT project. Okay, Hong Kong is facing a population aging and rising number of people living with dementia. Like for the population of 65 plus, we're currently having 20% already in our whole population, and the up-to-date population projection predicted that in 20 years' time, this proportion will rise to 31%. And for a number of people living with dementia, back in 2009, they estimated that there was around 100,000 people living with dementia. And according to a more recent estimate announced last year, we're now seeing that there will be around 110 70,000 of people living with dementia in Hong Kong. So you can see that this proportion is really alarming and is really increasing rapidly and more than faster than we expected. And another important context to understand is that Hong Kong is a developed, as you all know, Hong Kong is a developed city with a care system well established. And these systems are actually modeling on other high income regions or countries. But our problem is that we are now facing a more rapid population aging than those countries. And as you may know, in Hong Kong, people who are elderly or people living with dementia who need a service are facing a long waiting time if they need to seek help from the public health care and long-term care services. And for the dementia specific services and facilities in Hong Kong seems not meeting the demand of the people living with dementia. And at the same time, actually, Hong Kong do not have a dementia-specific policy and plan. And this is altogether the background why we started the TIPCA project. And at that time, although there is no lack of a dementia-specific policy, we see an increasing attention from both healthcare and social care sector as they raise some recommendations in the mental health review report and elderly service program plan. And okay, so we started the TIPCA project, and this is one of the major objectives. The first one is to assess the current dementia situation as compared to the expectation and needs in Hong Kong. So now you see this busy diagram. Actually, we did quite a lot of different work packages and component in this project. Here we have the first one is a rapid situational analysis, and it leads to another Delphi study and a desk review. And for these three components in gray color, I will only briefly go over them today. But my focus will be on the fourth and the fifth component, which will be our theory of change workshop and a SWOT analysis that we conducted on the dementia situation in Hong Kong. And it is the mainly the findings from the SWOT analysis and the findings from the theory of change workshop that altogether that give rise to the key challenges and opportunities that I would like to present today. Okay. And just a very quick overview of the first three components that I mentioned earlier. In the rapid situational analysis, what we did is a very quick review of the dementia situation in Hong Kong and reproduce this pretty infographic to engage the public and to engage different stakeholders for our different research activities. Like for the next component will be the Delphi study. And during that time, we send these infographics to the general public and the stakeholders to engage them into the Delphi survey that we want to do. And the second component is a Delphi study. In this study, we make use of online survey and telephone survey to ask different stakeholders about their priorities of dementia care. And the key questions we ask is, what would dementia care look like in Hong Kong in 10 years? And the answers, from the answers, we formulate the priorities of the service users and other stakeholders. And the third component on this right-hand side is an in-depth data review that we conducted mainly to understand the dementia situation in Hong Kong. And it covers these different components, and this desk review is already available in our project website. It's a very lengthy document. If you're interested, you can have a look. I forgot to mention one point. Actually, for this Delphi study, it is also already published. This paper is led by my colleague, Dr. Shi, who will be the last presenter today. So if you're interested in the method and the major findings of the Delphi study, you can also have a look at this paper. Okay, and building on this work, so you can see that from the from the rapid and the in-depth desk review, we try to understand the dementia situation more. And from the Delphi study, we try to understand the stakeholders and the users' expectation. Yeah. So there are two lines of thoughts which are interrelated between this component. And the next activity that we do is the theory of change workshop. Okay, and we mainly want to make use of this workshop to co-develop the visions and strategic plan among our key stakeholders in Hong Kong. So theory of change method is actually an outcome-based approach, which describes how a program brings about specific outcomes through a logical sequence of intermediate outcomes. So as you can visualize from this, picture I included here, actually, it is like a workshop that we brainstorm ideas, and we make in this mock theory of change workshop. Actually, we make use of this post-it, and we come together and make use of different colors to stick it on a wall to see how different ideas actually connect together. Okay, but in this TOC workshop that we did in Project Tipcard actually is a online version that we make use of Zoom to conduct the workshop, and we involve 32 representatives from multiple sectors, including family carers, people from the healthcare sector, government, the academic sector, the general public, philanthropy, subventive services, and self-finance and private services. So they're altogether 32 representatives in these two online theory of change workshop. And during this workshop, we asked them to discuss the following things, including the impact that we want to achieve, the outcomes, the rationale, indicator of success, and what would be the interventions and key activity that we want to do if we want to achieve this outcome. But today I won't go over all these details, but I will focus on the ultimate impact that we actually discuss and co-develop during that workshop. And here are the major outcome of the theory of change workshop, which is our vision about where do we want to get to in 10 years. And there are two visions. The first one is Hong Kong becomes a dementia-friendly city where people living with dementia and carers can lead normal life and age in place with dignity, meaning, and quality of life. Okay, let's keep this in mind first. I will later on recap on these visions. Okay, and the second vision is Hong Kong has reduced or slowed increase in number of people living with dementia through effective prevention. Okay. Moving on a little bit is the last component about which is the SWOT analysis that I want to introduce tonight. The SWOT stand for strengths, weaknesses, opportunities, and threats. So in this process, actually, our team members, altogether 7 members, project members with a diverse professional background, we read the desk review in details and to conduct this SWOT analysis. And just to go over a few lines to let you have an idea of what are the strengths or weaknesses that we are mainly talking about. For strengths, they are the factors that have stimulated strong dementia care performance, or factors that are considered as an advantage for meeting the policy goal. And for the weaknesses will be the other way around, factors that have increased the care costs or reduced care qualities. And there are opportunities. It refers to new initiative or area of growth that we think that we may leverage on. And threats may be are some factors that may cause trouble in dementia care or meeting our policy goal. And so, and we map these SWOT into different category, like the healthcare system factors, long-term care system factors, so on and so forth. And I want to highlight that in this matrix, there is a word, the policy goal in all 4 boxes. But as you notice, I have mentioned at the very beginning, in Hong Kong, currently we don't have a dementia-specific policy or plan. So what I'm trying to do today is that I'm trying to map the visions that we identify in the TLC, in this TLC workshop, with the SWOT that we identify from the Hong Kong situation. Okay. And one of the let me recap. Sorry, let me elaborate on the key features and strengths of the Hong Kong dementia care first. In Hong Kong, actually, we have a comprehensive public long-term care and healthcare system that provide universal, affordable, and territory-wide services. And these care sectors are actually financed by stable and recurrent public budget. And for the private sector, are the major provider of residential care services and the primary care services of the medical sector. And at the same time, we have NGO and charities that have been funding and implementing a wide range of pilot measures and services over the last few decades. And we have a strong informal care sector, including our family carers and foreign domestic helper, who play a huge role in dementia care. And last but not least, in the recent years, we have a new dementia-specific community service, which is delivered via medical social collaboration, providing support to persons living with dementia and family carers in the community. And here I try to map the key challenges and opportunities according to the visions that our stakeholders would like to achieve in Hong Kong. The first vision is about the dementia-friendly city where people with dementia and carers can lead a normal life and aging in place with dignity, meaning, and quality of life. So you can see that this vision is very much about whether or not our city is dementia-friendly and how our care is delivered in our society. Some of the major challenge is that actually we don't really know our current level of public awareness and attitude towards dementia. The last related survey was already conducted in 2015, and we have unknown diagnostic rate, and we guess that it might be quite low because in 2005, the diagnostic rate is only 11% in the community. And we can also see that there's a lack of a dementia-specific care coordination, and there are some problems of service fragmentation between different dementia services. And as you may know, Hong Kong, elderly in Hong Kong is heavily relying on the public services for healthcare and social care service. And we are facing a shortage in workforce and high turnover. And for the shortage in workforce, and it is particularly more serious in the recent years because many young generation are moving away from Hong Kong. And for services that support carers, we are facing an inflexible respect service. And there are some opportunities that we can leverage on for achieving this vision. The first one is to review and follow up on the dementia-friendly community campaign that was led by the government. And we have existing large-scale age-friendly city campaign, which are funded by charity in Hong Kong. And we may, in line with the latest policy address, so we may involve the primary care more in providing a diagnostic service in dementia. And we have existing voucher schemes covering both healthcare and social care, which may try to shift the burden on public service to the private sector a little bit. And there are task shifting approaches in the community, which are piloting or by different stakeholders. So it involves the training of volunteers or other community members. And the social welfare department are also conducting training on foreign domestic helpers, which are some opportunities that we can enhance informal care provided by these domestic helpers. And owing to thanks to COVID, we have more developed remote service and resources available in the community. So these are also something that we may leverage on. And the second vision is reduce or slow the increase in number of people with living with dementia through effective prevention. So this is very much about risk reduction and whether we have a clear picture of the prevalence of dementia in Hong Kong. So the major challenges are actually we are facing an increased prevalence of some important risk factors, including hypertension, insufficient physical activity, and diabetes. From 2014 to 2020, we observe an increasing trend. And at the same time, our population is aging very rapidly because age is the major risk factor of dementia. And we don't have a mechanism or regular information systems for dementia. Yeah. But luckily, we still have some opportunities. One of them is we have an existing action plan towards non-communicable disease, which although not specific about dementia, but we can actually are focusing on these factors, hypertension, diabetes that I mentioned on the left-hand side. And in recent years, we see a lot of more about dementia in social media, popular cultures, and also in celebrities appearing in movies. So these are some opportunities that we can make use of to promote public education at different levels. And last opportunity is about the prevalence rate. We are going to have an up-to-date prevalence rate from the Hong Kong Mental Mobility Survey for older people that we're expecting the findings probably in this year. Okay. And this will be my last slide. And for both vision, actually the key challenges is that we do not have a clear or widely recognized dementia-specific government unit or representative taking the lead or coordinating this development of dementia policy or plan. And as you may know, dementia service both healthcare and social care are involved in the provision of dementia services. And another challenge is that whether or not dementia is still a priority in our policy agenda. And we also observe there are limited support and attention for ethnic minority in general. And there's no dementia-specific research fund or planning. Yeah. And a few opportunities, one of them that we would highly recommend is to follow up on the recommendations from the Mental Health Review Report and Elderly Service Program Plan. And from TIPCARD, we have a co-developed roadmap that we may make use of. And also we have some dementia cost estimates from this project, which Dr. Shi presented on Saturday. And also some opportunities about integrating different database from the healthcare or long-term care service or dementia research hub or data sharing platform, which will be very useful and important for researchers or service planner. Okay, so I guess I will stop here for today. Thank you.
Right. Thank you so much, Jacky. So in the interest of time, I will ask you to save, if you have questions, save them towards the end of this presentation of this seminar, or put them in the chat. And meanwhile, let me thank Dr. Choy for summarizing a very substantial piece of work into 15 minutes. And I want to mention one thing about the work that Dr. Choy shared with us. So this comprehensive review of the situation in Hong Kong is actually the first step needed for a more rational policy planning. And it's actually the work that we are doing is in accordance to the Global Dementia Observatory that as individual countries and places to collect relevant information that is needed for policy planning. So with that, we have quite a bit of background information. And on top of that, what we need to know is what is the cost associated with dementia care. So that is what we're going to listen to next. And next, may I introduce Mr. Yingyang Zhang, currently our PhD student in the Department of Social Work and Social Administration. And actually, Yingyang has shared with us on another piece of research a few days yesterday, I mean. And so I will cut short the introduction, but just to mention that Yingyang has been very active in researching in using electronic health record to look into the healthcare utilization in people with dementia. So I think, Yingyang, you're going to share with us the work on the association of comorbidity with healthcare utilization in people with dementia, a population-based cohort study. So may I pass the time to you now? You may want to unmute yourself.
Yeah. Thank you, Gloria. May I share my screen?
Yes,
yeah.
Please.
Okay. Yeah. Thank you. Can you guys see the slide?
Yes.
Okay. Hi everyone. I'm Yingyang. The topic I'm gonna present is the association of comorbidity with healthcare utilization in people living with dementia 2010 and 2019, a population-based cohort study. And this is the co-authors of this paper. People living previous evidence shows that people living with dementia have a higher risk of hospital admissions, longer hospital stays, and more frequent primary care consultations and accidents and emergency department visits, and as well as comorbidity. In a comorbidity in people living with dementia, it's identified as a driving force to healthcare utilization in people living with dementia. And the relationship between comorbidity and healthcare utilization in this vulnerable group is complex. Population-based evidence can allow sufficient sample size and follow-up duration to discover patterns and inform policy. So why did we do this study in Hong Kong? Since evidence about this research has been done mostly from Western countries, and it shows that the prevalence of multiple long-term conditions in Western countries were very high, and Chinese population is identified as a key driving force of global dementia prevalence. Previous studies in China show that greater comorbidity burden may associate with length of hospitalizations. However, high quality, up-to-date longitudinal data are lacking. So in this study, Hong Kong is an aged city with the most highest life expectancy at birth. We used the 10-year population based electronic records between 2010 and 2019 in public hospitals in Hong Kong. Yeah, we aimed to investigate the association of comorbidity with healthcare utilization in people living with dementia. Let's move on to the methods part. The data we used in this study were extracted from clinical data analysis and reporting system. This system is managed by a hospital authority in Hong Kong. And in this study, we used the following ICD-9 CM codes to identify individuals with dementia diagnosis. And we selected those with any dementia diagnosis between 1st January 2010 and 30 June 2019. The index data was identified the first dementia diagnosis, and we followed them until death or the end of follow-up, which ever earlier. And the patient's records were de-identified for privacy. This figure shows the flowchart of study population selection, and after excluding those who were not eligible, we got 88,151 patients for our final analysis. Measures competency. In this study, we extracted the chronic conditions prior to or on the index date, and they were classified into 60 conditions, including dementia. And this measurement was developed by an international team, and then we define comorbidity as equal to greater than or equal to one condition simultaneously in addition to dementia. The number of chronic conditions was collapsed into these five groups. We also selected specific conditions of interest. We selected those whose prevalence was greater than or equal to 5%. And then we combine categories that were moderately or highly correlated. Covariates include age, sex, history of healthcare utilization prior to index date, and our outcomes is healthcare utilization, including risk of all-cause hospitalization and accidents and emergency department visits. We analyzed the unadjusted healthcare utilization rates by a number of chronic conditions and by specific conditions. We also fitted 4 negative binomial regression models for healthcare utilization associated with a number of chronic conditions and specific conditions. This device method was used to deal with missing values. And finally, we got 88,151 participants in the study, and most of them were women participants, and the mean age was 82.9 years. The median follow-up time was 2.5 years. This figure shows the prevalence of conditions in addition to dementia. We can find that hypertension was the most prevalent chronic condition in this dementia cohort, followed by cerebral vascular disease. And this figure shows the prevalence of a number of chronic conditions in addition to dementia. And it shows that 1.2% of them had 2 or more comorbid chronic conditions in addition to dementia, and 16% of them had 8 or more comorbid chronic conditions. And then let's move on to the model results. This figure shows the adjusted rate ratios for outcomes by number of chronic conditions. We can find that the rate ratios increased substantially as the number of chronic conditions increased across inpatient and accident and emergency departments setting. This figure shows the adjusted rate ratios for hospitalizations by specific conditions. We can find that comorbid kidney diseases had the highest rate ratios of hospitalizations, followed by chronic ulcer of the skin. This figure shows the adjusted rate ratios for accidents and emergency department visits by specific conditions. And we can find that comorbid chronic ulcer of the skin had the highest rate ratio of accident and emergency department visits, followed by chronic kidney disease and COPD. Based on the findings, we made 4 conclusions, and actually the prevalence of comorbidity in our dementia cohorts was similar to that in Western populations, and but a high rate of hospitalization and accident and emergency department visits possibly linked to later diagnosis, reliance on hospital and emergency care, and utilization of outpatient care. Healthcare utilization increased considerably with number of co-occurring long-term conditions, and we also found that the substantial differences by specific conditions, such as chronic kidney diseases and the chronic ulcer of the skin. So generally, based on what we found, our findings further highlights the importance of taking care of comorbidity in tailoring the care approach and developing health care plans for people living with dementia. Yeah, thank you.
So thank you so much, Yingyang. So this is a very interesting piece of work showing us how comorbidity can significantly affect the cost of dementia care. And I think this is very much related to the next talk. So I'll ask you to save the questions towards the end, because I think what our next speaker, Dr. Shi Zhang, is going to share with us will complement what Yingyang has presented, because Yingyang's presentation is focusing on hospital-based healthcare costs, and Dr. Shi will share with us the cost information from the long-term care perspective. So a very quick introduction, because I think you have seen Dr. Shi in the previous seminars and symposium already. But very quickly, Dr. Shi is currently research assistant professor at the School of Graduate Studies and Institute of Policy Studies at Lingnan University, and her research focuses on how social policy can respond to dynamic care needs against social demographic changes and its impact on formal, informal caregiving and service utilization. So without further ado, let me pass the time to you, Dr. Shi.
Thank you, Gloria. Let me share my screen. Okay. Okay. Hello, my name is Cheng Shi, and as Gloria mentioned, I'm a research assistant professor from Lingnan University. So today I will share with you findings from our study on long-term care cost and its association with a diagnosis for dementia and cognitive impairment levels. So on behalf of the team, I will present this study. The topic of our study of today's presentation is how does a diagnosis for dementia and cognitive impairment levels affect formal and informal care cost among publicity-funded long-term care recipients. Some background information. So we know dementia has a huge academic burden. Globally, the annual dementia cost can be higher than $1 trillion US, and 80% of this cost attributes to formal and informal care. And also, I think we know diagnosis for dementia is very important because it's a gateway to resources, support, and care services. But globally, 75% people living with dementia haven't received a formal diagnosis. And in low and middle income countries, this number is even higher, up to 90%. Most long-term care service users, they are more likely to have dementia given their care needs and their functional abilities and cognition. So according to previous study, we found that 2/3 of the care home residents and 55% to 68% of community dwelling older persons, they are living with dementia but haven't received a dementia diagnosis. And also we found there are not too many studies focused on the impact of diagnosis on care cost. There are only 2 relevant studies, but their findings are still inconclusive due to the heterogeneous components of care cost and care settings. One study using the evidence from Germany primary care, it found that diagnosis is associated with higher drug cost, lower total medical care cost, but it's not associated with formal care cost. Well, another study using the evidence from England residential care settings, it found the diagnosis for dementia is associated with higher total care cost and formal care cost, while this is the residential care cost. So there is a lack of evidence on the effects of having a formal diagnosis on formal and informal care cost across community and residential care settings. So our study, we used a data set from publicity-funded long-term care recipients in Hong Kong to address 2 aims. First, we aim to examine the impact of a formal dementia diagnosis on formal and informal care cost across residential and community care settings. The second aim is to compare the long-term care cost at different cognitive impairment levels between long-term care recipients having or not having a formal dementia diagnosis. The reason why we also have interest in the second study aim is that we've noticed that many, as I mentioned earlier, many long-term care recipients, they perhaps are living with dementia, but they haven't received a diagnosis. So we were thinking to try to control their cognitive impairment level to see whether they perhaps are living with dementia or not, so that we can further to see the impact of a formal diagnosis for dementia. Well, I will brief you the long-term care system in Hong Kong. The long-term care service in Hong Kong are mostly funded by government and provided to the applicants who are accessed as moderate to severe level of care needs, regardless their financial status. So this is a kind of universal long-term care system, not a mean test-based system. So all need to consider is their level of care needs. Only the care needs can reach a certain level, that is moderate to severe level of care needs, they will be eligible for Hong Kong long-term care. But as Jacky mentioned in his presentation, the waiting list, the waiting time for long-term care service, both for community care service and residential care service, is quite long. Okay, and here are the care facilities under the publicly funded long-term care services in Hong Kong. So our data collected in May 2014 and December 2016, this is actually the data from a government-funded project on long-term care service, previously led by Professor Terry Long. So we used the data from his project. The participants from this project, they are all the publicly funded long-term care recipients in Hong Kong, from community care settings and also from residential care settings. And our participants, they are quite representative when we do the recruitment. We use the step time measurement method to capture the care time and valuing the care cost. For each person, their long-term care cost is equals to their care time provided by different type of care staff multiplied by its union cost. We mainly use the labor cost of each type of care staff. And for the formal care service, we included medical, nursing, personal, behavioral management, and other professional care, leisure activities. So all the care services provided by the long-term care, provided in the long-term care facilities. And regarding the informal care, we included the care time spent for ADL, that is activity daily living tasks, and also some instrumental ADL tasks. But when we considering the time for informal care for people, for long-term care service user, we excluded the care time for household living tasks, like shopping and cooking. And this is the union cost for each type of care staff. Well, here you can see this is the list of all the care staff involved in our project. And regarding the union cost for informal carer in the community, we use the value for home helper. For cognition, we use an Interride Cognitive Performance Scale, that is CPS, to measure the level of cognitive status. This is a score ranging from 0, means cognition intact, to 6, means very severe impairment. And also we measure whether they have dementia diagnosis, or we identified whether they have a dementia diagnosis from an Interride assessment. And we also have included some covariants, including demographics like age, gender, and clinical characteristics. That is the number of diagnosed diseases other than dementia. And also we measured its functional status. Apart from the descriptive analysis, we also use the generalized linear model, GLM, with the log link and the gamma distribution to examine the association with the care needs, the association between care needs and care cost, and the diagnosis, dementia diagnosis and cognitive impairment levels. Okay, this is our sample characteristics. I would like to highlight the 47.6% of our participants, they are having a dementia diagnosis. And this number in residential care settings can be higher, that is 63%. And in the community care settings, 37% of participants, they are having a dementia diagnosis. And if we look at their cognitive impairment level, we can see that among some participants, well, this is the number for the participants living in the residential care settings. They don't have dementia diagnosis, but you can see here, many of them are showing moderate to severe or even very severe level of the cognitive impairment. Same as in the community care settings, some participants, the long-term care recipients, they don't have a dementia diagnosis, but they're showing a very severe cognitive impairment. And this is the average annual formal and informal care cost disaggregate by cognitive level, cognitive impairment level, and whether they have a clinical dementia diagnosis in residential care and community care settings. I want to show you here, as our focus is dementia diagnosis and cognitive impairment level. First of all, we can see that we can look at the percentage change. It means the increase between the cost for those with dementia diagnosis and from those with dementia diagnosis. We can see most of the percentage are positive. But here, this change number for informal care cost is negative. It means that the care cost for person with a diagnosis is not always higher than those without a diagnosis. So perhaps having a dementia diagnosis didn't trigger more resources or care services for this group of people. And regarding the cognitive impairment level, we can see that in most groups, their care cost increased along with their cognitive impairment level. The numbers in red colors is the most expensive cost. However, for the participants in the community, their formal care seems not increased by their cognitive impairment level. So these are initial observations. Then if we look at the results from the GLM analysis, we further explore the association between long-term care cost and the cognitive status and dementia diagnosis. The results here show that a dementia diagnosis was associated with an additional 50% increase in community care settings formal care cost. Well, here is a 23% increase for the total community care cost and a 13% increase for the residential care cost. While the diagnosis for dementia didn't, as I mentioned, it is consistent with the previous slides. Regarding the informal care cost, the diagnosis didn't show a significant results here. Well, for the cognitive impairment levels, well, we can see that, well, those numbers are all significant. And they show a gradual increase from lower level of cognitive impairment and to severe level of the cognitive impairment, both in residential care settings and community care settings, and also for the informal care cost. But for the formal care cost, this association is not so that significant. Okay. And we further presenting the adjusted cost by care setting, diagnosis, and cognitive impairment levels. Well, the first two figures on the top, it shows that the adjusted cost by diagnosis or without diagnosis by care settings. This is for residential care, and this is for the community care. And we can see that the adjusted cost for the persons with diagnosis, no matter their level of cognitive impairment, this cost is higher than those without diagnosis. And the same patterns has been observed for the persons in the community care. As you can see here, the cost with diagnosis is higher than those without diagnosis. And then if we look at the care cost in the community only, but divided by formal care cost and informal care cost, we can see that in the regarding the formal care cost in the community, the cost for those with diagnosis, they are higher than those without the dementia diagnosis. And we can't see an increase according to their cognitive impairment level is quite, we didn't see any slopes here. Well, for the informal care cost, well, we can see it's quite clear there is an increase along with the cognitive impairment level from the borderline intact to the severe, moderate to severe impairment. This is for the informal care cost. Okay. So based to our knowledge, this is the first study focused on the formal and the informal care service utilization of long-term care recipients with or without a formal dementia diagnosis and at different levels of cognitive impairment. Our main findings are, first, we found higher long-term care cost associated with the formal dementia diagnosis and the cognitive impairment severities in both community and residential care settings. Second, in the community care settings, we also found formal care costs more likely associated with a formal dementia diagnosis, while the informal care costs are also associated with cognitive impairment levels. So what does this mean? So first of all, we can see that a formal dementia diagnosis is a vital access of timely and adequate services in long-term care settings. Previously, we know dementia diagnosis is important, but our focus is on, the current study, they are focused on healthcare cost. Because we know after a diagnosis, there are some post-diagnosis service like drugs for the persons with dementia in the healthcare settings. Well, in long-term care settings, our evidence also show dementia, how important a dementia diagnosis is. And the second implementations is that for those without dementia diagnosis, but actually they have presenting same level of the cognitive impairment and functional abilities, well, it's very likely they have dementia, but they haven't received same amount service as those who have received a dementia diagnosis. So we say the care needs of those without a formal diagnosis perhaps be neglected. So there are some potential unmet needs. The last implementation is that, well, given the current high undiagnosed rate of dementia, we think perhaps a review on care planning based on the cognitive and functional impairment level may be needed, so that we can ensure those persons, they can have equal services, and the care facilities, they can equally deliver the dementia-related services and interventions in long-term care settings. Okay, this is the end of my presentation. Any comments and questions are welcome. Thank you.
Thank you so much, Dr. Shi, for the very detailed sharing. Because I think it's a good thing about these kind of research seminars is that we can go into more in-depth, go more in-depth into the methods and also the findings. So I think we still have like 2 minutes of time. If you have any questions, feel free to unmute yourself or put your questions into the chat box. Meanwhile, while waiting for your questions, I would like to have a bit of chat with Dr. Shi and also Yingyang, because I think what we're trying to do, well, first of all, what we see here is like a pieces of a big puzzle that we find out more about the different factors affecting cost in dementia. And from Yingyang, your presentation, it seems that there is quite a bit of cost associated with comorbidity, and that is coming from some like A&E and also inpatient hospitalization. So whether those costs are potentially preventable may be something that we want to know. Maybe that would be the next study. Don't you think?
Yeah. I actually, there are some studies about potentially preventable hospitalizations and accident and emergency department visits in people living with dementia. Yeah, I guess this is our further research. Yeah.
Yeah, and I think for both Yingyang's and also Cheng's studies, we are aware that in Hong Kong, actually, we do have a very high undiagnosed rate in dementia. So Cheng's presentation actually shows us actually having a dementia diagnosis may lead to substantial increase in use of resources. But what we do not have on hand with these two studies is that what those increased investment, if you like, could lead to improvement in other outcomes, and that might ultimately be cost saving. And this is actually what we are trying to do with the entire TIPCARD project. So with this information, and then we have also collected a range of information about different characteristics, people's different characteristics and care settings, and the unit costs related to those situations. Then we have the basis of future potential modeling, or if you are planning for budget, you can have some basis to see how your intervention or your service might potentially reduce costs or bring in return of your investment. So we're trying to provide all these information in an open access format. So after today's presentation, we'll collect your comments, and then we will try to fine tune the analysis and make information available on our website and through other ways. Now, I see that actually time is running short. I noticed in the chat box that there's a question from Dr. Leung about what is a voucher scheme. So although I don't think we can answer that question very shortly, but may I refer all of you actually to our website, TIPCARD website, where you will find information related to very detailed Hong Kong care system and health system and any related services, including the voucher scheme. And also in future, we'll put thank you, Maggie. So it's in your chat box, and in the future, we'll continue to feed information on that, and hopefully that will be a useful source of information for all of you coming from different backgrounds in research, in philanthropy, or other service providers. Now, so I have to apologize that we do not have more time for further discussion, but I hope that if you find this useful, we'll try to arrange similar research seminars in the future so that we can share more and have more interaction and ideas sharing. Thank you so much, everyone. So this is the end of our seminar tonight, and I hope you have a good night. Thank you.
Thank you, Gloria. Thank you all.